I love that topic. Let's talk a little bit more about it. My name is Lori Power, and my company is MP Benefits, and I'm a group benefit consultant. The goal here is to grow in knowledge, to grow in perceptions, and to broaden that conversation. Really, really pleased to have Phil come in and talk about the PharmaCare debate. I loved his perspective on it. He mentioned it in one of the SHifT shows, and I went, oh, stop there. We need to do a whole session just on this perspective, because it had been something that I hadn't thought of before. And where it started was when I'm reading the background on what the PharmaCare program, one of their goals, they have listed 3 goals on their panel mandate. And one of their goals is to recommend an initial list of commonly prescribed drugs and have a transparent way to add to that list as part of the PharmaCare program. And Phil had said, over to you, Phil.
Well, it was kind of an initial reaction of BS a bit. My own personal thoughts on socialized Medicare is I'm a big fan of it to a certain extent. And by way of introduction, my specialty is actually international benefits. I do expatriates and special risk. So many of the clients and many of the insurers I deal with don't have a socialized Medicare program. And so I'm lucky that I get to see firsthand just what that opposite of socialized Medicare system looks like. So it gives me a bit of a different perspective when I try and bring it back to Canada, and I'm quite happy that I live in Canada and I do have access to socialized Medicare. Having said that, the drug portion of it is one where I think maybe a rethink has to happen. As I see the PharmaCare nothing more than a political statement to say, okay, let's go out and get votes by giving free medicine to everybody, which is essentially the message to the public. The public doesn't realize, well, there is nothing that's free about it. You are still paying for it one way or another. You're just paying in a different manner via tax dollars, which are nebulous at best to try and get your head around it and figure out just exactly what am I paying for. So having said that, my firm belief is that medicines should be available to those folks who A, generally can't afford it, and B, require medications that are so costly, such as the biologics and some of the biosimilars and some of the very rare drugs that cost an astronomical sum of money and typically are pointed at children that require them and whatnot. This is where I think a socialized Medicare system should actually be looking at, to say, well, Phil and Lori and anybody else, that's working or has access to a benefit plan can certainly handle the day-to-day run-of-the-mill kind of prescriptions that are costing you $20 or $40, right? What you can't handle is the drug that now costs you $20,000 or $25,000 a month. So this is where, in my opinion, where the government should be stepping in and saying, fine, you guys look after it. And private industry has done a very good job of looking after drug programs and even now dental programs for 100 years. They've kind of got that under control. What they don't have under control is the biologics and the drugs that are costing, a couple of $100,000 a year. Well, who can afford that? So nobody can really afford that on their own. Even if you have a benefit plan, you're still ending up paying for it. So there's no free ride, whether it's public or it's private. It's just a matter of who's going to need it and at what level, and what are we prepared to pay for. So that's, in a nutshell, my opinion is, government, you look after the big ticket items. That's where everybody needs help. Do I really need them to look after my $60 worth of prescriptions a month? No. Even if I didn't have a plan that I pay for, I could still quite comfortably handle 60, 70, 80, 90, $100 a month. It's not going to kill me, and it's not going to drive me into bankruptcy. 25,000 a month might, on the other hand, after a couple of months say, man, I can't deal with this anymore. I mean, what we're
There
seeing.
also doesn't seem to be, Phil, though, a look at what provinces already have in place for those higher costing drugs. So we're here in Alberta, and one of the things that we have, and I know Phil and we talked about this before, we've been coordinating with the non-group program for a couple of decades, right? I remember the days where it was like $60 for $25,000 of pharmacy coverage. Now it's more expensive for sure, but it is still incredibly affordable for a family that has those high needs. So you take somebody who might have MS in the family, and that cost of that drug is $43,000 a year. Well, now we have that provincial program that you can coordinate with the benefit plan, and it takes those high costing drugs off. So for me, from my perspective, it's like, well, what's the National PharmaCare going to do? Is it going to disrupt that well-oiled machine a little bit? Go ahead, Wendy.
So Lori, is that similar to what BBD's brought out with their CHIP program for CGIB members then?
I'll let Melanie speak to that.
Yeah.
Yes and no. It's a different type of a pooling arrangement, but I think that there is ways that they're looking at adding like formulary guard and different things in to help with that conversation. But I don't think it's the same as what Lori's talking about. Like, I don't know if it'll disrupt. That's an interesting point, Lori. I wonder that as well.
I wonder too on the taxability side, right? Because when somebody is purchasing that provincial program, they're paying for it with after-tax dollars, and we pay for it, as Phil said in the beginning, we're paying for it with as taxpayers. So you can't be declined the coverage, right? There isn't, and there's that 3-month waiting period unless you're coming off a group plan, but you can't be declined it. So it's not medically underwritten. If you are an Albertan, you get access to the non-group program, you pay for it after, and the employers, they're very strict about this. Employers are not allowed to pay for it, right? So that's where I wonder, what do you think, Phil? Like, would it not be more streamlined, to your point, on taking care of the higher cost drugs, if when they're setting up these panels to say, okay, well, let's see what the provinces are already offering and how they're paying for it? Because correct me if I'm wrong, for those of you in Ontario, but the Trillium program is what it's income based. And do they not incorporate a payroll tax for part of that payment, or how does that work?
There's a payroll tax for health in the province of Ontario, and it is income, like it's income based or payroll based, right? So up to a certain level of payroll, you're paying this, up to a certain, beyond that to this, so on and so forth. But it's not really, I don't know if you classify it as income based or payroll based, okay? But the Trillium program makes you jump through all kinds of hoops, where I'm liking the sound of the Alberta based process because it's much more streamlined, and it sounds much more like what we're trying to do with the CHIP program out of BBD, only the CHIP program is private and going through a private group benefits program with clients, whereas that's more government based, right? And so I think that that's a very good program.
I think it's having private industry look after most of the healthcare needs, that we have right now is the way to go. They do it efficiently, they do it cheaper, they're much more on point. And then my fear of kind of the national PharmaCare program is you're just going to pick off all the easy stuff and make it look great and throw chaos into the world, to which 95% of the population doesn't need it, can certainly get by without it, to please a small segment of the population, when in fact what you should be really doing is looking after that small segment of the population that really needs it. You want to help me out? Help out the little kid that needs a drug called Zolgensma that costs $1 million a shot.
Yeah.
You know.
Well, when we're
That's where you
looking
need
at
to
our
go.
renewals, you bring up such a good point. My renewal from this morning, one of the things we do is we look at the drug listing. What is being claimed under the plan? And you know what? They don't bat an eyelash at anything under that, $500-$600 for the year. They don't. Like that's common, but they're starting to bat those eyelashes at those drugs that are costing the $1,000, the $2,000, the $5,000, and go, our plan covers that. How's that going to impact my rates next year, the year after that, 5 years from now? And can I keep up with those kinds of increases?
Yeah, well, I think the industry kind of shot itself in the foot with biologics to begin with. I don't think, and maybe it was just sheer ignorance, and they didn't really know how it was going to pan out. But allowing biologics into private drug plans, even though you so-called pooled it through this program, ultimately, at the end of the day, it's just moving money around at a different level. In my opinion, it should have never been allowed to happen. They should have just said, we're not paying for this, period. And you're seeing that now. You're seeing higher pool charges on renewals that are now in some cases approaching, the primary insurance level. And if left unchecked, I think they're going to even be higher at some point. If you just fast forward 10 years down the road, you're just back to where you were before. So that was a bit of a mistake. I think some are now correcting it by going to biosimilars and saying, well, we're no longer going to pay biologics, we're going to pay biosimilars, which are about half the cost. Still expensive though, but certainly more affordable than the biologic itself. And now the arguments that I'm hearing, well, I can't take a biosimilar, I have to have my biologic. And to me, it's kind of like the old patent drug versus to generic drug argument all over again, just at a different level, and 5 years from now, everyone will say, no big deal, it's the same thing. I mean, I get biologics and biosimilars are slightly different because even a biologic itself from batch to batch is not consistent.
Well, it's live, right? Like
So,
that's the difference. It's not,
it's kind of one of those things that someone could say, well, the biosimilar is just definitely different than the biologic. And so you could actually throw that argument back and say, well, actually your biologic from 2 weeks ago is not the same as the one you got yesterday, because it is different. So, I guess, I'm not buying that entire argument that I have to retain a biologic, and all the government plans are now backing off biologics and going to biosimilars and whatnot. So, no, that doesn't mean that those drugs are not required. And that's not what I'm saying. It's just who should be paying for those and remove those from kind of that private industry and let private industry deal with the 95 to 98% of the stuff that we've been dealing with over the last, course of 100 years. We do a good job of that.
well, what stakeholders have been involved? That's my question is, it seems like there's a lot of headline out there. There's a lot of we're gonna, and then the deadline, we're gonna do it by the end of the year. Well, how is that? Like, it just boggles my, actually makes me have a bit of a headache. I don't know about you guys, but it's like, have you talked to the pharmacies? Have you talked to the drug providers? Have you talked to the insurers? Have you talked to anybody? And where's the dialogue happening?
Haven't heard anything myself.
No, anybody else?
At all.
I hear a lot of announcements and, I read a lot of, rhetoric, but I'm not even on, as we said before, even on the National Dental side, did they even reach out to the Canadian Dental Association? And, Phil, you made a great note when I said, well, I have a good friend of mine who's a pediatric dentist in England. And so she falls under the National Dental Program. And Phil said, did you see the average teeth on a Brit?
It's not a pretty sight.
So is that what we're going for? Or, you know, you get the fillings, and I don't know about you guys, but on that dental note, I'll just say that as a kid in the backwash of Nova Scotia, we didn't have a dentist in our area at all. So our school system had the dentists that used to go to the different schools and look after us. Anybody else have that kind of experience? If you did, you know, feel my pain. Because everything was a filling. So I have like probably about 4 or 5 fillings here where they took the tooth and they just like scrapped it out. And as an adult, I've gone to the dentist and they go, "My God, your teeth." And I'm like, well, you know what? You could have had a pinprick for a of a, you know, abscess or whatever, and they were taking that whole tooth out. So if that's what national dental looks like, that somebody can say, yeah, you know what, we took care of all those kids and they all got their fillings. Like, I wouldn't wish that on anybody.
Mhm.
That's my bird there. Now we got
Everybody's
crickets in
silent
the
around.
room.
And then imagine the ropes you'd have to, you know, jump, or the hoops you'd have to jump through to get something approved. You know, it would have to meet all a certain criteria, especially government funded or any type of programs. There's so many different forms and procedures that, you know, your private dentist would just go in and do. Whereas they might say, well, you know, it doesn't quite meet this as our standard that we have this box to fall under. So it's you're right, Lori. It's just not a good situation for, I think, helping the little guy, and just overall, I think it might just be a mess personally. But
well, and I think you bring up a good point there too, because if we look at our general practitioner doctors, right, our system is based on a least costing alternative health system. Because that's why all of us in this room probably know business owners, or maybe we've done it ourselves, that they'll go down to the Mayo Clinic. One, because they get the best of the best. There's no waiting. They pay for the service. They get fixed and they come home. Whereas those same people will be on a waiting list, have to meet with the general practitioner, get a referral for a specialist, get a referral for the surgeon, and then be on a wait list for surgery. So what are we looking at? Maybe a year, 18 months? Typical hip, right? Is that what's going to happen in the dental community, where we're very used to setting our every 6 months, every 9 months, we have that regular maintenance? Will we get that same service, which is you get what you pay for, or are we going to then transition to a least costing dental program because it's a national program?
right, then the generalist becomes the enhanced program instead of the specialist being the, you know, the better service. And yeah,
Right.
it might become the lowest tier service.
And right now, I mean, our plan members can choose, right, whether they want, you know, $1,000 a year or $1,500 a year, or whether they want to cover 80%, or, you know, that kind of thing. They have options. They're not going to have that when it's a government-run program. They're going to have, this is what you get, and it's not going to be anywhere near what they're used to. In a group plan. Sorry, speaking of,
I mean, you know, again, coming back to what, you know, universal health care was really meant, in my opinion, was to really look after the catastrophic type illnesses and then expenses that can hit a family. And I don't think people realize that, you know, if you go into a hospital here in Canada, you know, and have appendicitis and have your appendix removed, you know, and you may end up with if you stayed in a semi-private room, you may end up with, you know, $20 or $30 bill walking out it as a copay for the luxury of having a semi-private room. Well, flip that over to the United States, whereas, yeah, that same 3 or 4 days in the hospital, that just ran you $50,000.
Yep.
An appendicitis attack. So, you know, when you look at it and say, okay, you know, can you go down to the Mayo Clinic? Sure you can. Are you prepared to pay for it? Because your government's not going to pay for it. They're not
No,
gonna
and you're absolutely right. So don't get me wrong, Phil. I'm not saying that I want to remove our healthcare system, but when they're making blanket statements and proposals of this is what we're going to
Yeah, no,
offer.
and that was my point, was
Yeah.
actually agree with you, is to say, I don't think, Joe Q public understands just exactly how expensive it is.
Yeah.
They say, well, why can't I just, US healthcare is so much better, I don't have to wait. Well, yeah, you don't have to wait, but you do have to pay. So, if you don't want to wait, well, then nobody said that you couldn't go down to the Mayo Clinic and pay your 50,000. Knock yourself out. I personally, if you've got the money and you want to go down there, send yourself down there and good luck. And you know what? Just frees up a little bit of space up here in Canada for those that can. But
That's right. It gets rid of the lines, right? That's what we argued about. What was that 10, 15 years ago when private practitioners came in, and the big argument of we can't offer private doctor services. Well, now look at it. Now we have private doctor services. That's great. They've taken matters into their own hands. They have these clinics, but have a look on it on the public side. How hard is it to find a family doctor now?
pretty difficult.
It's pretty difficult. My doctor retired. It's like, well, what do I do? She's like, I don't.
I mean, you're always going to have discrepancies. And yeah, the American side has great access. Canadian side, not so great access. Its cost is to us personally is relatively cheap. Even if you are paying a premium, Albertans don't pay anything for, in addition to what we fork out in taxes. We don't have an additional premium like some of the other provinces do. But even if you're paying $80 a month for a family and additional premiums to provincial health care, if you didn't have that, if Canada were like the United States, and everything was private, a family of four, depending on your state, could run you as high as $3,000 to $4,000 a month in premiums. So now you're talking about, an annual premium of $30,000 to $40,000 a year that you have to pay with after-tax dollars just for healthcare.
Yeah.
So if you want to know the reason why when you see all the shows down in the States, like Dr. Pimple Popper, why the guy left that bulge on his neck for 25 years, it's because he has no insurance. He couldn't afford it in the first place.
No. And you're absolutely right. You're 100% right. But I would appreciate, I guess, if somebody, whoever is in the know, whoever that somebody is, if they start talking to stakeholders. So those of us that have to talk to the employees, have to talk to the employers, have to coordinate all of these things, are better prepared to support it. And I think that is the general miss, is if you brought those stakeholders into the conversation, we would probably be the biggest advocate, because I would say to any employer who on a national PharmaCare program, be like, this is wonderful news. Let's have another look at your plan design and how we can accommodate that for the best of your employees. And we would be those advocates going forward. But it's almost a closed door and making us the enemy instead of the friends to the program that we could be.
Yeah, I agree. I think with a national PharmaCare program, I don't think any one of us would have an issue of our taxes going up slightly to pay for a drug that little Sally needs because it's going to save her life. I am not opposed to that at all. Do I have a problem being dinged a tax dollar? So, Mr. Thompson of Thompson Newspapers can go out and get his $40 prescription for free.
Yeah.
Not what I got a problem with. He can afford it. Thank you.
And the thing is that we are, on that note, you can imagine the great conversation we could have with the employer if we say, you know what, we know that you have one employee with Crohn's and colitis. Isn't that great that those drugs are going to be covered under the National PharmaCare program? that's not going to impact your experience going forward. And this is how we have built your program for, like, we really could be fantastic advocates for it if only
It's
they
interesting,
open
and
the
I
book.
don't know if any of you have clients that are in a position now that they're just saying, you know, they just can no longer afford it. They can no longer afford their benefit program. You know, they get constant increases. It never goes down, even when it should go down. If they happen to be lucky enough, they never do. But they're just saying, you know what, I've got X number of dollars, and right now I'm at that limit. And so now it's a wholesale slaughter to their benefit program. You know, they feel sorry for the one employee that has a biologic drug that's costing them $250,000. And he's saying, you know, I don't have a law that says I have to provide benefit coverage, so therefore I'm not. And I will give everybody X number of dollars a year. That's all I'm prepared to do. And sorry, Phil, I feel for you, but frankly, your problem is not really necessarily my problem.
Yeah.
And it's a very, very harsh attitude some are taking. And I'm not too sure that I entirely feel that they're unjustified for feeling that way. I
Anybody
always
else
remember
have
years
the,
ago.
and there's the ghosting effect too, Phil, don't forget. And I call it the ghosting effect because who here has clients that have allowed anti-selection for that exact reason? They have employees who have been on the plan for a while and not high users on the plan, and they opt off and they go to the employer and say, I cannot afford this. I cannot afford to participate. You need to remove me. Now the employer terminates them, just that employee, from coverage, reducing the amount of participation in the plan, which makes everybody else pay more. That's one aspect. But now they've put themselves into a liability risk because now they have anti-selection going on. What happens if something happens to that employee, death, disability, you name it, or that high pharmacy need, right? Like there's those two aspects of one, exactly what you're saying. They just get rid of the benefits, but the ghosting, I would say, could be tremendously more costly to them legally than just terminating the plan in itself.
Yeah, no, you're right. I mean, there's a lot of kind of unwelcome things that go along with this. You know, at the end of the day, I'm kind of a dollars and cents. What's going to happen for dollars and cents? You know, at the end of the day, it is about money. When we get down to it, I mean, yes, we all talk about employee health and all of the wellness and all of those great things, and they're all important. But in the final analysis, for a lot of employers, it comes down to money. What can I afford, and how much money do I have? And how can I work within my parameters? And right now, the drug costs are just going through the roof. And they're, you know, everybody's looking at ways to shift them around. And there's only so many ways you can do this, you know, whether it's through, you know, a pooled scheme or through stop loss coverage. At the end of the day, somebody still has to pay. And it's not the insurance company that's going to pay ultimately.
No, and it's not our federal government either that is going to pay. And you know, and it really does. If we as a community, if we as benefit advisors and people who are in insurance, if we want to change that conversation of what benefits really are, from that commodity to that investment, we need to get a handle on this, because that exact conversation that you're promoting here, Phil, is exactly what will continue that commodity conversation, because how can it not?
And the communication and approach, I think, Lori, too, like you said, it's really a miss, because it could be handled so much differently. And communication of, oh, well, this is great for everyone, it's going to save Canadians whatever the number is, $5 billion a year. Well, it's actually going to cost us 15, 30, whatever it is, $1 billion a year to pay for all of this. And, you know, bottom line is we're trying to help those that don't have it, which needs to be first and foremost. Take out those high biologics, you know, deal with that so we can help the mid-size and these, you know, just everyday mom and pop employers and everyone really. And just find another way to fix our healthcare system, not this way. This is not a way to fix and just try to become like every other country or whatever they're trying to do. It's not the answer. We need to actually put that money towards incentives to get our doctors back here, to get our healthcare opened up, to just so many other areas. But again, we're not involved in that conversation. Like you said, if we could be advocates to help communication part go a lot better, I think, we're hands-on in this area every day. So
Absolutely. And Melanie makes a good point. That's why there's such an uptake on that CHIP program, because it is needed. But we need to somehow, my expectations of being included in the conversation are nil. But it's having the conversation here, I think, where we can learn and best approach our clients, because our clients are asking those questions and they are more in the dark than we are because at least we understand the mechanisms and we understand that pricing model. So we are well positioned to do that. Last words, Phil, as we come top to the hour.
Not really. I mean, other than if governments continue down this road and what my opinion is, they're going to cover all of those things that are easily covered because it's politically expedient to do so and it looks good. Is it what's necessary? In my opinion, no. They're going to actually carve out those things that are really needed, where the government should be stepping in, and not cover those. And it's going to have the opposite effect on everything else. Everybody will love the PharmaCare program, not realizing that it's just becoming another government department that's overbloated. Requires a couple of million people to actually administer it.
Oh my God, the bureaucracy, Phil, you just added a whole nother level.
Incredible, as opposed to saying, I will just pay for this one drug because it's needed and it's catastrophic, because that's where we should be. I can see that happening just because of the politics, and no amount of talking with the government is going to change their mind.
No,
And
I agree.
you're going to, all those people that need those drugs and require them, where are they going to be? Those are the people that are going to actually get left out and left behind.
Yeah.
And you're going to get, all of the news stories about, little Johnny required that and the government wouldn't do it. And then they'll capitulate on a one-off basis. And then, that $1 million drug, by the time that he really required, it probably is going to end up costing them 10 million by the time they get through all the rigmarole and get it paid for. Typical government stuff. It sounds like I have a bad attitude towards governments, but they've proven time and time again they're really terrible at this stuff.
They really are. It's almost depressing to think about the dominoes that haven't even been. I started with stakeholders, and now you've just taken me to a whole other thought process on that bureaucracy and the.
Keep it simple.
We can. We could keep it.
Let private industry look after all of it. Because at the end of the day, I mean, if you have national PharmaCare programs and national dental care programs, actually, we alluded to earlier, Laurie, now you're killing a bit of an industry too.
Yeah.
You're killing all the brokerage industry. You're taking a large chunk out of the insurance industry, or what they do. So.
I see it more of an opportunity, though, too. Like I am going to stand by saying that if it was done well, if what they were doing is what you're saying, Phil, and they're taking care of those high costing dental, like, I don't know, somebody who might need implants or what have you, right? If they're taking care of those high costing biologics and they're removing that, I see that being a tremendous advantage for our industry. Like, I really do. I see that as we could be that advocate that I would go to every client and say, listen, this is wonderful news. Let's revamp your plan design. And what an excuse to do a much better job.
Well, it certainly lends itself to other forms of insurance, not just pure insurance. Now if you don't have that huge risk, now you can get into a bona fide ASO and with some comfort that you can actually manage those healthcare dollars in a reasonably sane way. That's not to say that you still may have pluses and minuses, but certainly you take out the impact of one person and one drug. If you've got that out of the equation, then you can run a relatively, smooth sailing benefit program. And actually get to the point where actually you're providing a benefit. You know, as
Put the benefits
it's a
back in
benefit,
benefits.
you know. So
Fantastic. Thanks everybody for coming today. I would like to have this conversation again in a couple of months if you're up for it, Phil, because I think as it grows and evolves, I think if we can come together and scope out and connect and get a deeper understanding of things and share perspectives, I think that'll work really well for the clients that we serve. So I hope you're game, and then we'll do it again, Phil.
absolutely.
Thanks so much for coming by. Reach out anytime. I love the conversation.